afternoon, and thank you, Dr. Love, for giving me this opportunity. Pediatric cataract surgery in infants, my topic is. So we need to operate them as early as 6 weeks if it is unilateral, and if it is bilateral before 8 weeks of age. Very few children actually present at this age, but now with the with the awareness programs, we are picking up children as early as 8 weeks. So if early surgery, the biggest problem is anesthesia related complications, because it may be easier to do the surgery, but I think the most difficult task what I find is anesthetist and anesthesia. So the other is because the eye is microphthalmic with varying degrees of developmental arrest in the cornea, iris, drainage, angle and retina. So we have to be careful, and that means complication rates of aphakic or glaucoma is very high. So even if there is a PHPV also, we need to look up, especially when you're seeing the ये आप कर रहे हैं अच्छा वही कोई और मैं सोचा मेरा हाथ जा रहा है. Okay, so the PHPV is present in up to around 25% of all congenital lens opacities. ये आगे नहीं जा रहा है. So the challenges are basically what I find is that the main challenges are whether to put an IOL or not to put an IOL. Axial length increases rapidly in the first 6 months, and we know that up to 1 year the axial length is increasing rapidly. Steeper cornea with high keratometry values. So whether to put an IOL before 6 months of age or after 6 months and 1 year, I'm convinced that we could put an IOL. Less than 6 months, I'm still not convinced. I am still controversial whether I should put an IOL or not put an IOL. So sometimes I feel in bilateral cases, should I wait till 6 months and then put an IOL? So because the target refraction, what I find is that whatever you calculate, I have reduced 10 diopters in less than 2 months, 3 months. I have reduced 9 diopters in 2 to 3 months. 4 to 5 years, I reduce 8. But I still find the prediction error is not predictable at all. Every time after, there are surprises, and that is what is scary. So less than 6 months, I put an IOL, but I'm not sure what my prediction error is going to be. So I would advise you can undercorrect as much as 8 diopters when the child is around less than 6 months of age, if you're putting an IOL. And so infantile aphakic study was done by Dr. Wilson and Lambert, and they found that they had a lot of problems. In our studies, we have done, we studied the prediction error we put the IOLs in children less than 1 year. It was 66 eyes. I said, let me do a study myself and see my evidence based. The IOL power ranged from 15 to 40. I have even put a 40 diopters in some, and in that case, in those 2 cases, I found the maximum prediction error. They are now 3 to 4 years of age, and they have a minus 15 refractive error. Prediction error. So I'm always wondering whether I should have put, and those babies were 2 months of age, and I had put a 40 diopter IOL. Still, the prediction error in those babies were around 15. So those 2 cases I'm following up very closely. I may have to explant or do an IOL exchange. So less than 6 months and very high. So what I found was that do not put an IOL if in less than 6 months. If you are putting an IOL, do not put it if your axial length is less than 18 millimeter, because lot of prediction errors. If you have an axial length more than 18 millimeter, please go ahead and put an IOL. But less than 18 millimeter, all the 3 cases which I got surprises were less than 18 millimeter. So don't put them. And that's the only factor which affected the prediction error. Myopic shift also was seen much more in patients who I operated less than 6 months with an IOL. The mean logMAR visual acuity of both of the cases were very good. Of the bilateral cases was 0.482, which is very good, and even the logMAR visual acuity was 1.033 in the eyes with unilateral cases. PCO rate was comparatively less, of course, because we have good vitrectomy machines, and though infant aphakia study said that their main rate of reoperation around 74 to 82% was because of the membrane formation. But I think because we do more cases, I'm not sure, or our rate was not so very high, but we still need to do a bigger rhexis, and no glaucoma was seen in children when, at least in the pseudophakic variety. I did not find glaucoma in most, it's therefore I'm talking of only 66 eyes. It's not, but now recently also I may have added on around maybe 100. No, there's been no case of glaucoma, but aphakia, yes, I've had cases of glaucoma. So that could be one advantage. I think there are better videos than me by Dr. Arup. So I would not, I'm just showing you few Dr. Arup has wonderful videos. I've seen his videos, and then, you know, I feel like, okay, my videos are not very of that quality. But I just want to say that anterior capsule access, I still do it with the Utrata forceps, though I've seen all the other surgeons do. I'm quite comfortable with my Utrata forceps. I've been using it from the last 25 years. Of course, the microrhexis forceps used by others is equally very good. And the biggest advantage is that you don't have to make an incision in the main port, and you can still do the rhexis. Now, the biggest nice challenge in pediatric cataract, what I find, is the variety of, you know, you get different types of PCC, posterior capsule, you get different varieties of anterior capsule. So because of its rigidity as presented in the previous talk by Dr. Khoker and the rest of the team, I think the rhexis is something which we need to keep on practicing. So how I learned was that I first did it in children, you know, say 2 years more. If you go from backwards as learning curve, say 8 years to 6 years, I do the cataract, and then I go back. And I find that the capsule is much different when you go to younger children. So it is, so this is with the microrhexis forceps. I do only few cases with the microrhexis forceps. I'm still comfortable with the Utrata. So this is the microrhexis forceps where you need to, I use Helon in children because I find that using visco, it's not a question of money. You will not get the same result as with visco because you know, you are keeping on injecting and the visco keeps coming out. So it's better to do with Helon because for the child, it's once, you cannot make mistakes in this. So the posterior capsule, I'm not going to, so if you have the posterior capsule also, it is important that, you know, now this posterior capsule rhexis, I make a nick and raise the flap, and I do it manually because I am quite comfortable manually. I only do it with the cutter when I find that it is very, very flimsy. Like in some pediatric cataracts as small as you know, you find that the capsule is very, very flimsy, and so it does not get stretched on it, does not get pulled. So moment you feel it cannot get pulled, it's better to go with the cutter. But the disadvantage with the cutter is that I find that it is not smooth, the edges, and when you are putting the IOL, then there's a tendency for it to extend. So I find that the manual is much better. Even if I've had a case where my IOL had dropped, I mean, I put the IOL, had gone into the bag, and it was hanging like this inside the, I pulled it up, pulled the lens out, my PCC remained intact. So that is a best of the manual PCC. So so this is with the cutter. If we have cases like this with thick posterior capsules, in this you have to use the cutter. The problem with the cutters now I'm facing is that now most of the companies have stopped the 20 gauge cutter. I don't know if all of you know that they have stopped 20 gauge. Now they give us only 23 gauge and 25 gauge. Like we have Centurion Constellation, which gives us only 25 gauge now. These plaques don't get cut with 25 gauge. So you need to use then you need to use a retinal forceps, scissors. 23 gauge still cuts this, but I still find even with 23 gauge, you're not able to cut all these thick thick plaques. So, but the companies have just stopped making, like, you know, I'm going to come and I decided to go and ask why they stopped making 20 gauge cutters. So, because these are few cases where you need the cutters. So, so one thing which I would say is that microcornea, less than 9 millimeter, I will not put an IOL in a small baby. Ethically, it's not right to put an IOL because I find that they develop more and more complications. And if I see on my axial length, if I measure and I see less than 18 millimeter, I still will not put an IOL. Otherwise, I'll go ahead and so I still do it with the Utrata forceps. So with the Helon, this is a 11-month baby, and so we this of course this rhexis will come with, you keep putting Helon because it's a smaller baby. What we find that it keeps getting so the rest of the procedure, what I find is that if you can do phaco as adult cataract surgeons, pediatric cataract is not very difficult because most of the steps, I think, from have we grown over the last 30 years, because we you know, we have I find that we see now the procedures much simple because that time we didn't have phaco. So we were not using these techniques. But I think the tunnel, the Rexes, the bimanuals, all this have revolutionized pediatric cataract surgery, and you hardly find. Now in this case, I had to use the cutter, so I use the cutter now. Now the cutter for the flap is different than the cutter for the vitrectomy. So you use, like suppose now I use the turbo because we have on turbo and constellation. So in that, then we have to increase the you have to make the cut rate less for the when you're putting for the flap, and you can increase the cut rate to around 1000 for the vitrectomy. So if you fear that the you do not want the IOL to go down, so you can, sorry, I have decided to suture. You can put it first in the iris, and then you can rotate it into the bag. And Acrosofts, I'm not, there's no financial here, but I still use Acrosoft single piece lenses, and they're very easy to put into the bag. So we don't have to struggle with your PCC. The important thing, of course, is the follow-up. I'm not going to go more into detail. I think my time is up. But what I would say is that do not fear a phakia, yeah? Because I have now, this baby is grown big. He's just now, all of these are babies who have operated. They are studying in college. I put a secondary IOL after a phakia. They're doing PLI4. This is just 2 or 3 cases I'm presenting. But don't think that we have to put an IOL, and don't mess up the eye. Like this baby, this boy, he has a corneal diameter less than 10. I have not put an IOL. Microcornea. His father was a pharma industry. He told me, please put it. I said, I will not put an IOL because his corneal diameter. Today he's in 12th standard. He got an award, and he's 6'9", and his glasses prescription only +4, +5. And he's a phakic, and just on anti-glaucoma drops. But I think we should not be overdoing when we put an IOL. And I think that's all the message I wanted to convey. Thank you.
Thank you, ma'am. And do we have any question? Just one query I had. +40, which company did you get?
No, +40 I get from SP.
Achha.
Single piece. MP has only up to 30.
You will get from AIOC.
Oh.
AIOC are able to make up to +60.
Okay. But
Yeah, but that is a hydrophilic material, but that is it's a bit bulky. It is bit bulky, like Renner design.
Acrosoft, SP single piece.
6.
Yeah.
Up to 40. Yes.
MP you don't get. Multi-piece up to 30.
Multi-piece is 34.
34 you're getting multi-piece we're giving in Delhi only up to 30.
yeah, up to
Sorry, 30.
Oh, it's very thick. Very thick. No, it's difficult. I'm not saying.
what I do, I generally don't implant more than 30.
Johnson and Johnson is up to 34.
No, see, these are when we are younger, and these are all my old cases. Now I wouldn't put it here. So I'm just saying, when we are younger, we want to put IOL in all children. But they are now, the child is having that 40 which I put, in spite of that, which is having a biopic shift of -15. So I'm regretting putting it. So now, so what would you advise? You will remove the IOL, or you put an iris claw on top of it? If it's a -15.
No, it's a small eye, no?
Very difficult.
To remove
Even explantation, a whole bag will come out.
the whole bag. So I was thinking just to put an piggyback,
Small eye.
No, now the child is big. Now the child is 6 years.
But even then, eyeball size is not.
Drastically, yeah. Steep corner.
Yeah. Poor prediction in early age is more due to K changes rather than axial length.
I'm so sorry. Sorry.
Thank you.